Dr. Nebojsa Lalic. Pardon me if my pronunciations are not correct. And he is the director and head of the Department of Metabolic Disorder. Also, intensive treatment and cell therapy in diabetes, clinic for endocrinology and diabetes metabolic disease at the Belgrade, Serbia. He is a professor of internal medicine at the Faculty of Medicine, University of Belgrade. He is the Dean of Faculty of Medicine in University of Belgrade. He is a member of Serbian Academy of Sciences and Art. He is the chair of National Expert Committee for Diabetes of Serbia, and he is the president of Serbian Diabetes Society, and he is the chair-elect of IDF Europe. And he is going to tell us about the ironing out glycemic variability with appropriate insulin choice. Dr. Lalic, please.
Distinguished Chairman, I would like to thank first of all the organizers and especially Vanshi Sabu for the invitation to be with you today and to give a talk. Now I will try to share my slides. Can you see them now?
Yes, doctor.
Okay, thank you. So my task of today is to try to put on the table the possibilities, the options, how to iron out the glycemic variability with the appropriate insulin choices. This topic has been very up to date in the recent years when many insulin formulations have been discovered. And when, on the other hand, we discover the glycemic variability is an important option for the to tackle for the optimal treatment of diabetes. That is why I will compose my talk with the first short introduction, and then I will be talking about glucose variability as itself, especially with reference to hypoglycemia and chronic diabetes complications. And then I'll try to in a systematic way, say about what types of insulin treatment are promising in reducing glycemic variability with some final conclusions. So let's start with the beginning, the introduction. That is the basis and the dogma that we took with us for many decades, if you wish, that we should evaluate the control of diabetes through three main parameters, and that is fasting plasma glucose, postprandial, and HbA1c. And we thought that it would be enough. And in routine practice, it is more or less what we do. However, the data were accumulating that it is first of all not only HbA1c enough to assess glycemic control, and sometimes can be misleading, but also the changes of blood glucose, and as well as the variability of blood glucose, and not only the fasting and postprandial values. That with some technical upgrading that went in meanwhile, especially with the CGM, continuous glucose measurement, we became aware that we should go back to glycemia, to its variability, of course, not to forget HbA1c, but to put the control of diabetes in a more complex basis. That is, it is important, and there are a lot of evidences that it is important, because if you look, and this is of course a classical approach, to two patients that have almost the same HbA1c or similar, like these two in this subject 1 and subject 2. At this slide, you can see that the glycemic variability in subject 1 is really huge, with a lot of deep hypoglycemias, while with patient 2, subject 2, we don't have these phenomenon. So in this context, and if we look only at HbA1c, this very important fact for the control of diabetes in these two subjects would be neglected. So that it finally appeared important and accepted by almost everybody that apart from the three parameters that we used for many years or decades, we should include glucose variability as the fourth cornerstone of the evaluation of blood glucose or diabetes control. And how to approach glucose variability. And you can see that you have a list of different markers, and of course you cannot get enough measurements in any environment, in any practice to evaluate these metrics. And but usually how all this story ended up is that by these days a coefficient of variation is something that is used as a measure of glucose variability, and measuring in fact the amplitude of glucose variability. But however, and that this approach has been prevailing until now when we speak about the glycemic variability. But in an effort to go deeper into the control, especially in type 1 diabetes, and especially in patients using new technologies in diabetes, such as insulin pump, group of American Diabetes Associations have decided to go further on in defining the recommendations, what can be important for the control of diabetes in these patients, and to launch new parameters for evaluation of diabetes control, which can come from CGM, from continuous glucose monitoring. And they said in their recommendations that glycemic variability, in other words, stability of coefficient of variation, should not be higher than 36%. So we have now a goal to reach, and this is what is important, that glycemic variability evaluation now became quantitative, and it is there is an attempt, there is an effort that every patient in the practice, especially type 1 patient, falls into this category. And that is about introduction on glucose variability as an important parameter, which became very important in the last couple of years in the evaluation of patient, first of all, type 1, but also of type 2 diabetes on insulin as well. Why is, from pathophysiological aspect, glucose variability so important? Because it is very tightly related to hypoglycemia and late diabetes complications. And you can see here the famous slide that is connecting the intensive treatment in DCCT study in the intensive group of patients, which shows that with the decline of HbA1c, have with the changes of HbA1c, you can have the changes, the positive changes of retinopathy. But the other side of the whole story is shown on this slide, and that is that in the intensive group, in fact, you have the increase of severe hypoglycemia, which is shown on the left side of the slide, and that in fact it goes as well with decreased retinopathy as together with good glucose control. By that time, it was not so important in the eyes of the investigators, who were happy to find some way to prevent diabetes complications. But however, by the course of time, it became visible that in fact you decrease the complications on the but the cost is high regarding severe hypoglycemic episodes. And that is, of course, that poses the question how to avoid it. On the other hand, some later studies have shown that glucose variability predict hypoglycemic events even in patients with type 2 diabetes, because if you look, those ones who have a great standard deviation of their blood glucose, and you can see that hypoglycemic events are the most numerous, especially in this group. So that the glucose variability can have a sort of physiological meaning in a way that can be the background on which hypoglycemia can develop also in type 2 diabetes. And the third aspect, which was underlined also from 10 years ago on, is the effect of glucose variability on vasculature and oxidative stress. Jerriello and his group made some studies evaluating the relationship between the changes of blood glucose. You can see these three groups: one with stable hyperglycemia, one with stable, let's say, almost normoglycemia, and one with the great oscillation. And you can see that the flow-mediated dilation of in these patients is the worst, is very much affected in type 2 diabetes, especially in the group having the blood glucose from 5, oscillating from 5 to 15 millimoles per liter, so that FMD is here very severely affected. Something very similar happened in the situation which is not very frequently elaborated, and that is what happens after hypoglycemia. Because the changes, if after hypoglycemia we have hyperglycemia, which is rather frequently the case, and the cause of glycemic variability, we have the same picture of affected FMD, which then, but not FMD, the increased production of IL-6 and of some prostaglandins that are responsible for the atherosclerotic changes. So glucose variability might be the basis also on some unfavorable changes in the vascular wall and leading to atherosclerosis. Finally, the changes of blood glucose with the different with the simultaneous hyperglycemia and afterwards hypoglycemia can induce increased production of free radicals in mitochondria that can cause many changes, that can trigger many pathophysiological intracellular mechanisms, some of them leading to are the classical ones leading to microvascular complications like polyol pathway or increased PKC production, but also there are others who are very much related to macrovascular complications, such as increased expression of NF-kappa beta and increased presence of age. And this is the way how, in fact, glucose variability together with oxidative stress can be another channel amplifying the risk for both macrovascular and microvascular complications. In this context, glucose variability is not just a burden for obtaining the good glucose control. It has the meaning, an important meaning as an initial change for the for life-threatening hypoglycemia and atherosclerotic changes. And that is why there were a lot of attempts to try to decrease glucose variability with the use of insulin treatment. First of all, this curve of increased severe hypoglycemia at the same time retinopathy was decreased from DCCT attracted the attention for many years, and that was one of the reasons to try to find some insulin formulations that would at the same time lower blood glucose and prevent late complications, but without such a high risk for severe hypoglycemia. And the discovery and the introduction into practice of the first generation of insulin analogs was in fact the first step in that direction. And because you can see that in comparison to NPH insulin with insulin analog, you can just decrease this relationship and obtain the same effect without severe hypos. And here, of course, the same process has been continued. And in this slide that is used many times, you can see that two most frequently used insulin analogs of the first generation are really decreasing the glucose variability, and that is and insulin variability, and that is clearly shown at these columns, but also at these graphs, making an adequate environment for the improving of the situation regarding the glucose variability of insulin therapy. That is not only when the whole aspect of the kinetics during the day is concerned, but also the overall, when you see what is the reproducibility of the overall blood glucose lowering effect, you can see that with these two insulin analogs of the first generation, you can obtain much better results than with NPH insulin, and that meaning glucose exposure tends to be more consistent in comparison to NPH insulin. So in this context, the same stands for a maximum blood glucose lowering effect, which is then also more suitable for good blood glucose control in comparison to that one with NPH insulin. So you can use them with a lower risk of inducing increased glucose variability. Finally, second generation of insulin analogs brought in also more potentials in regarding the daily glucose variability, and you can see that with some of them, really the daily glucose variation and can be for very low in when they are compared to the first generation of insulin analogs. It can be 4 times lower, and regarding the regarding the daily variability, analyzed with a very sophisticated approach with the use of insulin clamp. Somehow simultaneously to that, there is a lot has been done with the work of insulin pumps, which merged some 10 years ago with the with the glucose sensors, and created some 5 years ago world's first hybrid closed loop systems, in which were for widespread use, of course, in the countries that they can afford it, and in patients that are in the system that can afford it. But this sensor and the respected algorithm can really enable the control in which glucose variability is very much decreased. The number of companies that is really working on that is increasing day by day, and there is a lot of chance that at least for type 1s we will have a good tool for decreasing glucose variability. That is how daily download, as they call it, or the daily profile of glucose can look like in a patient. And you can see that the majority of values of blood glucose values are within the normal range, but it is to be noted that this is not a miracle by itself, and that here you can have some peaks of glucose here and there during the day or during the night or early morning hours, which should be all the time adapted, and for which, unfortunately, the algorithm is not something that can emulate this changes. But however, the situation is much better than with any other approach regarding glycemic variability. So finally, if you would let me conclude after all this, is that evaluation of glucose control in diabetes comprise not only testing of postprandial and preprandial glucose and HbA1c, but also of testing of glycemic variability, which is an important variable. That glucose variability is found to be an independent predictor of hypoglycemic, especially severe episodes, and increased glycemic variability diminishes flow-mediated dilation and increases oxidative stress, which might be the basis of cardiovascular damage. That's why it is something we should not forget in any patient. On the other hand, insulin therapy has always been associated at the very beginning with human insulins with increased level of glycemic variability. However, that became in the focus of the next attempts to improve the insulin therapy, and even the first generation of insulin analogs brought in decreased glycemic variability, thus enabling safer use of this type of treatment in the prevention of chronic complications without frequent hypoglycemias. Even more, second generation of insulin analogs, especially basal ones, exerted even better removal of both hyper and hypoglycemic episodes, although still not perfect, but however with an important advancement. And the use of sensor augmented insulin pumps with appropriate individualized algorithm can decrease glycemic variability to really marginal levels of importance for the control of diabetes. But of course, the limited use of this device, of this technology, still does not make it a sort of universal tool for the patients for the patients in any of our offices. Thank you very much.